We now move to the first thematic block of the day, prevention and cardiovascular risk factors. This session will explore how advances in prevention and science can be translated into measurable population health impacts and implemented at scale. The session will begin with a presentation by two fellows from the co-fund Cure Heart and Brain program at the CNIC. Please welcome José Antonio Valverde López and Javier Laura Francés.
Cardiovascular diseases are a leading cause of mortality across Europe, with 1.7 million dead, but also, and importantly, it's a leading cause of disability, with over 20 million people suffering from cardiovascular disease. Preventing a disease from starting and progressing, it's much more efficient than treating the complication when it's established. That's why prevention is a powerful tool, and cardiovascular disease is a clear example of this. Why? Because risks start early, while developing habits and lifestyle. Cardiovascular disease progresses slowly and silently. But once clinical events appear, it's cardiovascular disease, it's very difficult to reverse. The main risks are diabetes, hypertension, high blood cholesterol, and smoking. Normally, these are related with unhealthy lifestyle, unhealthy diet, physical inactivity, or stress. That's why it's so important to develop good habits and a healthy environment, especially during childhood. As we mentioned before, cardiovascular disease progresses slowly and silent, without showing symptoms. Because of this reason, millions of Europeans have subclinical cardiovascular disease, which remained undetected. Early detection is crucial. Early detection and early intervention before the symptoms appear prevent the disease to appear and allow us even to reverse the disease, while acting too late means treating complications and also just focus on delay the progression of the disease. Currently, new biomarkers, advanced imaging tools, and a continuous monitoring and AI prediction models are allowing to detect subclinical disease early, and also to improve the risk stratification. All these allow us to prevent cardiovascular disease and, of course, the irreversible damage. Atherothrombosis is responsible for strokes and myocardial infarction. However, the mechanism of thrombosis are not well understood yet. Understanding them and identifying them will allow for better diagnosis and better prevention strategies. This does not rely on pharmaceutical drugs, but also lifestyle has an enormous importance. Healthy nutrition, physical activity, and not smoking are a key pillar and are crucial for cardiovascular risks. Currently, poor long-term adherence for a healthy lifestyle, unhealthy environment, or socioeconomic inequalities are important challenges. However, with new policies, a better access to food, and prevention education will allow a better prevention at the population level.
Prevention should not depend only on individual willpower. People are much more likely to change when the system supports them. If healthy choices are easy, accessible, and reinforced over time, prevention becomes part of daily life rather than an extra burden. Mental health is part of cardiovascular prevention. Stress, depression, anxiety, and loneliness can shape how people sleep, eat, move, and follow treatment. If we ignore mental health, we miss an important driver of cardiovascular risk. A patient may understand the advice and still struggle to follow it. Daily life can make prevention difficult. Pressure at work, family responsibilities, cost, stress, or limit access to healthcare. Precision prevention must include the person's real context, not only their biology. Prevention requires investment, and resources are limited. Health economics modeling helps us to understand where prevention creates the greatest value. The goal is not simply to spend less, but to invest where we can prevent more diseases and disability. The value of prevention goes beyond healthcare cost. Preventing a heart attack or a stroke also means avoiding suffering, disability, hospitalization, and pressure on families. Prevention creates value for patients, for families, and for society. Clinical trials are essential, but real life is often more complex. Patients in daily practice may have several conditions, take many medications, or face social barriers. The challenge is to make evidence work not only in trials, but also in a routine care. We often know what should be done, but the system does not always make it easy to do it. Lack of time, poor data systems, limit workforce, and lack of trust can all interrupt prevention. Evidence only matters when it reaches the patient. Prevention can increase inequalities if it only reaches people already connected to healthcare. Equity must be designed from the beginning. We need to reach people who are at high risk but are often missing from prevention programs. So the opportunity for Safe Hearts is to connect the different parts of prevention: risk prediction, biology, lifestyle, mental health, value, and implementation should not be a separate conversation. Together, they form one prevention system. And the final message is simple. The future of cardiovascular prevention is not only better prediction, it is better action. We need prevention that starts earlier, reaches more people, and fits real life. We must predict less and prevent more.
Thank you very much. I would now like to invite onto the stage the moderator and panelists for our first round table. Moderating this session is co-fund Cure Heart and Brain fellow Marcos Daniel Machado Fragua.
Welcome everyone to the panel Prevention and Cardiovascular Risk Factors. We are very pleased to bring together today experts working across translational cardiovascular research, epidemiology, prevention implementation, imaging innovation, and corporate health. We are joined by Dr. Borja Ibáñez, Scientific Director of the CNIC and Interventional Cardiologist at Hospital Fundación Jiménez Díaz, José Luis Peñalvo, Director of the National Center for Epidemiology at Instituto de Salud Carlos III, Cristina Pérez Herreras, Corporate Health Director at Banco Santander, and Javier Sánchez-González, Clinical Scientist, Southwestern Europe at Philips. So, throughout this discussion, we will explore how prevention science can better translate into measurable population health impact and how Europe can strengthen prevention strategies through surveillance, innovation, public engagement, and implementation. So let's begin with a first question for all panelists. Europe just has generated strong scientific evidence in cardiovascular prevention, yet implementation and population-level impact remain uneven. In your view, what is currently the main barrier to translating prevention science into measurable cardiovascular health improvements across Europe? So, if you want to start.
Sure. No, thank you very much. So it's a great pleasure to be here and be discussing this very important initiative. I think this greatly exemplifies that this is a matter of different stakeholders. We have to work together. And in fact, coming directly to your question, I think the main reason for this, and well, one of the main reasons, is that for many, many years we have been working in silos. So clinical scientists, we have been working among us, and we have done great science. All the other stakeholders, the industry, the policymakers, and many other stakeholders, we have been working together. And even when you come even to prevention, even this has been for a long time the matter for epidemiologists and preventive scientists, that Sometimes they have worked together with cardiovascular scientists, but some other times they have worked directly on their own research and on topics. So I think this has been one of the reasons why implementation of the great results that we have had in science and in many other aspects have not been uptaken by the general community. So I think that a great example is the Safe Hearts Plan, which is not a plan done by the European Institute of Cardiology or the cardiovascular community, but this is a plan done by the different stakeholders. And in fact, this is going to make the real change. Because no matter how good is the science we do, no matter how great are the trials and the epidemiology or the cohort studies that we do, we know very well from many years ago that early detection of cardiovascular risk factors and intervention is the way to go. But still, this is not being done today, so this cannot be implemented. So I think that working together with different stakeholders can make the difference. And also another example we have here, Cristina from the Bank of Santander, for example, is that non-traditional stakeholders should be involved in this task. So, for example, the companies and all the different even ministries and public spaces, they should be part of this. So once we are working together from the very beginning, I think is when we are going to have a chance for implementation of what we have already known from many years.
Thank you. So, Cristina, if you want to continue.
Yes, I think, as we are saying here, Europe have created a huge amount of evidence about cardiovascular disease and cardiovascular prevention. But knowing is not the same as doing. So for me, this is our challenge, is to translating the knowledge into doing, into action. This is the challenge for us. There is no one stakeholder that can achieve a good level of population impact. We work to work together all here. I am, and we are here, the people who can achieve this goal. Work together. I think this is the solution for this gap between the knowledge and the action.
Okay, thank you. So, José Luis Peñalvo.
Thank you, and thanks for the invitation to CNIC. It's difficult to say it in English, and to Astra for hosting us today. So I would agree with my colleagues in that everything is very fragmented when it comes to research. But I would like to go back to the first point on why we don't see an impact on CVD reduction, and I think it's because we probably don't have the most robust systems to monitor and survey the burden of CVD in Spain and in Europe in general. So I think I will start with that, trying to strengthen the way we measure the burden of the conditions in the population with enough granularity that you can go into a little bit more, I would call it precision public health, targeting the right segment of the population, those that are most affected, and also targeting with the interventions the most appropriate phase of the life cycle where the intervention might be more effective. And in the lack of cohesive approach to cardiovascular health, I think frameworks as the one that Kitty presented today, I think they're going to be very valuable to bring us all together. But we still need to think of how we're all going to do that on the ground level, because that's very high perspective, very, very good. But it is very difficult to ground it. We talk about the amount of data that we have, how great it will be to connect all that data to improve the prediction systems, or even to improve the modeling activities that we do. But still, the data that we are collecting is very imperfect in many cases. It's very heterogeneous, and that needs a lot of work. So that the data that we gather, we need to treat it, we need to modify it so that it produces reliable evidence. Yeah, so that will be my take on that.
Okay, thank you. And lastly, Javier Sánchez-González.
So, well, first, thanks to AstraZeneca and the organizers to invite us as Philips. So it's for me an honor to be here. So I think that just quoting the words of the other speakers, I think that we need to work together. I mean, not only the the researchers who are targeting the key points to target, but the policymakers as well, to make a policy to cover all this, but also industry is critical here, I think. Because when you are entering in the implementation phase, you need solutions. And then you need solutions to target what the researchers are targeting or are highlighting and what the policymakers are targeting, I think. So in this sense, I think it's key to work all together in order to do a plan for prevention. Not only just researchers and policymakers, also industry, I think, plays a critical role there.
If I may add something, sorry. Maybe I forgot the most relevant stakeholder, which is critical, which is the general population.
Yeah.
Because no matter how good, I mean, now we are working together, but in the end, especially when talking about prevention, then if the population is not willing to undergo a screening test or risk factors control, then this is not going to be implemented at all. Yep. And in fact, I think it's, we are using the analogy with diabetes, for example, that maybe 40 years ago or 50 years ago, if a person that was completely symptomatic got a blood drawn and 200 milligrams per deciliter of glucose, and the doctor says, you have to take insulin, then the person would say, no, I'm feeling fine. Whenever I feel ill, I will go to the insulin treatment. But these days, I think the entire population is, or most of the population is very well aware that if they are not doing something, even at the asymptomatic stages, this is going to come with great problems later on. So for cardiovascular disease, I think it's the same. So we have data from our studies that we have done, all of us together, and many of you who are in the audience, that we know that, for example, atherosclerosis, which is the basis for most of cardiovascular diseases, is present already in about 10% of the population between 20 and 30 years of age. And if you go and you talk to a person which is 25 years of age and say, okay, you have to start doing some interventions, even sometimes with medication, I would say that most of the population will say, okay, I will wait a little bit. And even from our standpoint, especially from cardiologists, we heard from Hector that we are developing the clinical guidelines based on the evidence. Even we don't have any preventive strategy for persons who are below the age of 40. So this is because there is no strong evidence, but still the whole system is not taking this very seriously. So I think maybe I'm not going to ask the question, but it would be good to know, for example, many of you who are here, all of you, how many of you have obtained your blood pressure within the previous 12 months? How many of you? Okay, so still we are highly selected population, but still there were maybe 20% and maybe they didn't want to raise their hand. And if we go for the cholesterol levels, it might be the same. But even if we go further, do you know if you have some silent atherosclerosis? Then maybe half of us will say, okay, I don't know, I have never undergone any screening test. So if we are not convincing the general population that this is extremely relevant at this early time point, we are not going to achieve the whole prevention paradigm. Yeah. I'm sorry for this.
Can I follow it? Yeah. I would like to follow it about the rationale of Borja, but also if you think also the devices. I mean, you have a blood pressure device at home now. You have a pulse oximetry system at home now. So we need to create technology that can be at home. I mean, can be access to all the people. I think this is key whenever you want to target the population level. Need to go at home. I think that's a key factor.
Yeah. So thank you for your insights, your interesting insights. And now I would like to address some specific questions to each of you. So if we start with Dr. Ibáñez. Dr. Ibáñez, how can mechanistic and translational cardiovascular research better connect with large-scale prevention strategies and real-world implementation?
Well, this is a great question. And in fact, one of the main reasons why CNIC is now at the highest level, I would say, and maybe this is, I shouldn't say this, but this is the reality, is because Dr. Fuster from the very beginning had very clear that we have to connect very closely basic researchers with clinical researchers. Because still today, in many places, and a decade ago this was even stronger, clinical scientists, they are doing great clinical science, and they believe that basic science, well, this is fine, but they are doing their own things, and well, I don't understand them, so it doesn't matter to what I'm doing. And for basic researchers, it's the same, but in the other way. So, okay, we are doing the actual science, and the clinical researchers, they are just playing around with subjects and so on. But it is important that they have a very close connection, because if we are focusing only on the translational aspect on the general population or the application clinical trials and human beings or cohort studies, now we are translating what was basic research 15 years ago. For example, these days, everyone knows that, for example, these GLP-1 analogs, the Ozempic is and all these different drugs that they have here, everybody knows and says, okay, this is coming from out of the blue. But this was basic research 20 years ago. So they identified this receptor, and it was a very nice story, but I will not go into details. So this is why it is critical that we are educating the basic researchers in doing clinical science and the clinical scientists in the great value of basic research. And when it comes to the prevention, for example, at the CNIC, we have had within our cohort studies, PESA, REACT, and many others, always we have had a very strong core of basic researchers. And in fact, many of the great advances that we have had within these cohort studies has been made by basic researchers. One key example is that, for example, we have identified that clonal hematopoiesis, which is mutations that are not from the since birth, but they are acquired during adulthood, they are causally involved in the development of atherosclerosis. So this is going to open new venues, for example, for doing precision medicine, in which subjects in which we know that they have this clonal hematopoiesis, maybe they should undergo specific treatments. So this is why it's critical that even some of us that we are more into the clinical part, we acknowledge what is the relevance of basic science, because it's going to be the only way that we are continuing to having some discoveries that will improve cardiovascular health of society.
Okay. And what are currently the main translational gaps between cardiovascular research and prevention policies, Dr. Ibáñez?
Maybe I don't want to monopolize this, so maybe we can get there. Because I can keep talking for many hours, but I think so.
So let's continue with Dr. Pérez Herreras. So Pérez Herreras, what role should companies and civil society play in promoting a stronger culture of cardiovascular prevention?
I think the role of companies in this time for improve health culture and improve the cardiovascular risks into cardiovascular prevention is very important, not only because we are spend a lot of time in our work altogether, but because for us, for Santander, for me, the workplaces have to be the place where culture of health begins. But we have to challenge all of together, create a sustained behavior change. So for people change his behavior, people need understand their risk, have practical tools, very important, as they say, have practical tools, feel motivated to change, and have a support in good conditions, support about health. So I think our challenge is translating this knowledge, this science. Science already exists. Implementation is the challenge for me and the companies, and all together have to improve this challenge. If not, the science alone is not enough.
Okay, thank you. So now it's the turn to José Luis Peñalvo, Dr. Peñalvo. How can epidemiological surveillance and burden of disease analysis help Europe move from cardiovascular prevention research toward measurable population-level impact?
Thank you. Well, as I was saying before, I think that's the start of everything, just to measure what the problem is, what is the size of the problem. We need to know how many premature deaths are happening every year due to different CVD conditions. We need to know overall the mortality of the condition, but most importantly, as José and Javier were saying before, we need to understand the disability that CVD carries. That's the true measure of the burden of disease. As treatments improve and new technologies are coming to the population, mortality decreases and early mortality also decreases, but disability increases. And I'm talking about not individual disability, but population disability. So the fraction of the population that is living with CVD, it's getting bigger and bigger and bigger. And that's something that we need to address, and that can only be addressed with primary prevention. So you start with the framing of the issue. The better the data you have, the more precise you can be on what's needed to be done. And then I see it a little bit as a circle or a cycle, better said, on how to proceed about it. If you understand what the problem is and you know what the segment of the population is carrying more disability, and you know the exact or the approximate time when this disability starts to onset, then you can start piloting some interventions. It could be workplace intervention, it could be a school-based intervention, it could be a whatever community-based intervention. You pilot test that, and then you move on into, if that's doable, then you move on into a true effectiveness or efficacy trial. And if that works, then you go into implementation and scalability, which is what's lacking most of the time. In the research that we do, we often go to, oftentimes uninformed about what the true problem is, into pilot testing or efficacy trials. Those are normally successful, but we lack the continuation and the closing of the cycle, of the circle, going into implementation, evaluation, and then hopefully seeing whether the burden of the disease has decreased or not. So that's how. And also the burden of disease, in general, these studies serves a foundation for modeling. So when you have the baseline of the state of health of the population, then you can, with the right kind of inputs, you can try to model what would happen if certain aspect of the policy scenario in a country or in Europe will happen. And then you can sort of inform theoretically the best case scenarios and prioritize policy scenarios.
Thank you. And now, lastly, we are going to continue with Javier Sánchez-González. So, what role can imaging, digital technologies, and innovation play in scaling cardiovascular prevention and early detection?
Well, no more, no less. So, well,
you have only 15 minutes.
15 minutes. Okay, let's
take your
start.
time.
So, well, I think that well, cardiovascular, conventional or traditional cardiovascular risk factors are good to population management, but are not so good at patient-specific management. I think that's the key. So, imaging has the capability to see the disease. No, we can see which is the plaque in the arteries, in the peripheral arteries, femoral carotids, in the coronaries. We can assess which is the functional beyond ejection fraction of the heart. So we are able to see many things that are patient-specific. I think one of the targeting, it's one of the key capabilities of imaging is that it's able to target the disease-specific. So one thing that, I mean, as I said before, I think that this is going to be in the prevention phase whenever it's reaching the home, let's say home, I mean, pharmacies, whatever. I think that digital innovation plays a role there. I mean, we need to step out from high-end research sites as CNIC is to population-level solutions. So that's a key challenge that digital can play, that digital transformation can play here. Also, how to make technology easy and affordable for the people. That's, I think, the key.
If I may complement Javier's question, because maybe some of the audience here, they don't actually know what technology which we are referring. We have here some researchers from the AI POC Boost project that we have in CNIC. And the basis is that we know that if we identify which subjects are developing silent atherosclerosis, then our hypothesis is that if we are targeting and treating this very early, this is going to result in a massive reduction in cardiovascular disease. Today, we're working only on risk factors, and then based whether they have blood pressure and cholesterol, more or less we are guessing which one should receive treatment, but we are advocating that if we were actually seeing where is the disease, we can do this much better. But the problem that we have these days is that the technology is very expensive. We are using very fancy three-dimensional vascular probes. They are only in some hospital environments or research centers, and this is very nice for the generation of knowledge, but this cannot be implemented worldwide. Yeah. This cannot be implemented even in Spain, or this cannot be, not talking about the low and middle income countries. So we are putting this at the center of prevention. We need something that can be applied, as Javier mentioned, at home or in the pharmacy or in the companies. And this is why we are working in trying to simplify this technology, and we are using now portable ultrasound equipment, which is this portable ultrasound that can be hooked to the mobile phone. And even with artificial intelligence, we are making this pretty simple for even somebody who is not an expert in acquisition. They can do, and they can use the ultrasound, and assisted by artificial intelligence, they're going to, okay, go up, right, left, okay, wait, move, and you can identify whether anybody has atherosclerosis or not. At that, only when we reach this, and this is available worldwide, is when we are going to be able to implement this at the population level, because otherwise it's going to be something really fancy, we generate great data, but this is not applicable.
Yeah, sure. Thank you. Thank you for your interesting thoughts. And now to conclude, I would like to ask one final short question to all panelists. So what recommendation would you give to young scientists who want their research to contribute not only to scientific discovery, but also to real population-level cardiovascular prevention?
Yes. As I said, I think you are talking about this in a very good mood. I think you have understand what the situation is, that what the problem is, and I think in this case, the collaboration between public and private institutes is very, very important. Not fragmented, don't separate the mediums, but is not efficiency at all. And our challenge is empower the people to take the ownership of health, of their health through the care, the self-care, and reach the population. Don't stay in the science. Only science is not enough. And each person, each employee has influence in their family, in their community, in the society. So our role, our collaborating role is very, very important for us. And for example, our collaboration, our partnership with CNIC in studies as PESA and REACT take the evidence, the science into the companies, to the people. For me, this is very, very important. Take the science to the people.
Okay. So it's a very difficult question because it depends on what type of scientist or researcher you are. What is your daily job? But I would say that nowadays it doesn't work anymore, that you work on your own field of expertise or interest. So if you're a lab scientist, you work on the lab. If you're a data scientist, you work with a computer. I think you have to be aware of the overall field and be knowledgeable of other type of research that feeds into your own research. So if you want to make if we want to make an impact at the population level, that's the final target. But the conveyor of that impact is normally the Ministry of Health. So you have to be aware what's in the making in the Ministry of Health. What are the strategies? What are they using? What type of data they are using to inform their, not decisions, but at least the plans, and work from there. So if the plan for country X is reduction of alcohol, then you could steer your research into that so that it is meaningful to your customer. So that means that you have to really be aware of other disciplines. I wouldn't like to finish without saying that all that we're talking about here is very, very important. Prevention, primary prevention, secondary prevention, the continuum, the accumulation of risk. And it was said before, but they are also much bigger forces than our individual will to adhere to healthy behavior. So to educate ourselves on how to improve our overall health. There are social determinants of health, and there are commercial determinants of health that also need to be accounted as a foundation of cardiovascular health. These are the drivers of most of the risk factors that are being accumulated over the life course. So bottom line is that be open to other research fields. Don't just get obsessed with mitochondria or don't get obsessed with regression models, and be open and try to be cohesive in your research.
Yeah. Well, I have the same view, so I'm still think as a researcher. I'm a researcher, so I work on the industry. But I think that normally when you are a researcher, you are extremely focused on one specific problem or target because you have to. But also I think it's important to step out and also to look at the process as a whole. And also to ask you, when you are doing your research, which is the added value of my activity in the whole process, not only in the process that I'm studying. I think that's key. That's key to make more sense of the research that you are doing, but also to make more sense at the population level when you want to translate your research funding to the population. That I think is when you are doing health research should be one of the end targets. So I think, as an advice, just step out, look the whole process, and see how your process is there. I think it's also important that we are extremely focused. Sorry, just very, very briefly. We are very focused on high-end research. I think it's key, important. No matter what. But also we are in a moment of innovation, which is, I think, when you are moving things for research to the population level. I think that's an aspect that new researchers shouldn't skip. I think that they have to be focused also on implementation, innovation processes as well.
I was going to say something that they have already highlighted, but to the young researchers, I would tell them three main things. So open-minded, collaborative, and lead by example. So open-minded because, they can work in whatever research, but as my colleagues, they have highlighted, it's very important that they are collaborative and they are try to, even if they are working on a very specific topic, try to sometimes to be like in a more bird's eye view. Because we have seen many research careers in which somebody is working for a very specific topic, and then 20 years later, this is a moving target, and the disease, for example, is not relevant anymore. Yep. So if you are working for many years on trying to improve myocardial infarction impact and so on, because infarctions are very large, because we don't have any therapy, and then you keep working for 30 years, maybe you realize that still today, this is not a problem anymore, so problems are different. So this is why I'm trying to be collaborative, and now we're in a very exciting moment in which technology is contributing a lot, interaction with many other fields. And the last point, it's related to cardiovascular prevention, I say lead by example, and we have some colleagues here, and I mentioned, for example, that I know from our POC team, that lead by example means that if they know that early detection of disease matters, then be the ambassadors and then do the early detection in themselves. So they have done this, and they are doing this, and if they are spreading the word, and they are scientists, I think the population, they are acknowledging a lot researchers, or they are listening what researchers are telling, so if they can become the ambassadors for cardiovascular health, I think this is going to be great.
Okay. So thank you, all of you, for your contributions, for your insights. I think they are very relevant. Thank you.
Thank you very much.